Welcome to the Soho Forum, a monthly debate series that features topics of special interest to libertarians and aims to enhance social and professional ties within New York City's libertarian community. We're partnered with Reason Magazine in presenting these debates, and you can catch audio of all our events on the Reason podcast, which you'll find in the iTunes store. Tonight's resolution is as follows. The U.S. government should offer a Medicare-like plan that would be available to all Americans buying health insurance. Defending the resolution, we have Paul Starr of Princeton University, author of The Social Transformation of American Medicine. Paul, please come to the stage. Arguing for the negative, we have David Goldhill, author of Catastrophic Care. David, please come to the stage. "12 minutes for the negative from David Goldhill."
Well, thank you, Gene, and thank you everyone for coming tonight. And Paul, it's a pleasure to share the stage with you, and truly an honor. The Social Transformation of American Medicine is the first book I ever read about healthcare, and frankly, the first book anyone should read about healthcare. It's extraordinary. I want to start with a story, which I think is against the rules. 4 years ago, one of my best friend's father was told that his aortic valve was going to fail at some point. He needed a valve replacement, and the sooner the better. He consulted the cardiac surgeons at 5 big New York hospitals and was stunned by how aggressively they pursued him. He was a Medicare patient. He was 83 years old. Part of the Medicare argument is that Medicare pays prices so low that hospitals lose money on patients. He didn't experience that. In fact, they pursued him so aggressively that he was interested in a less invasive procedure that was part of a double-blind trial that was being conducted at New York hospitals. And one of them said, "We have a way of getting you in the procedure regardless." He had the valve replacement. Roughly 90,000 Medicare patients a year have a valve replacement. And according to Medicare, it was a perfectly successful operation. He was alive 30 days later. And in fact, it was miraculous. He had his valve replaced, was out of the hospital in 4 or 5 days, was walking around. 4 months later, he was dead. And the reason he was dead is because at some point, he banged something, some part of his body, on something. And he bled to death because everybody who gets a valve operation has to take anticoagulants. Now, the reason I'm telling this story is because it's unbelievably common. The last time somebody looked, and it's about 5 years ago, of the 2 million Medicare beneficiaries who die in a given year, roughly 700,000 had surgery that year. Out of every 5 over 90 who die in a given year, 1 has surgery. And there's almost no surgery recommended for somebody over 90 because the risk-reward is terrible. It's very convenient for those who care about politics to talk about access to health care, money. How do we pay for people to get health care? As if it's some black box, some commodity. Well, I'm going to violate 2 of the rules of talking about health care tonight. One is I'm not going to pretend it's this black box that we just buy. I'm going to pretend something that we all know is true, which is how we pay for it determines what we get. And the second thing I'm going to do is I'm going to leave, not often, the island of healthcare, in which we tell ourselves that all that matters is healthcare. There was a hilarious piece in the New York Times talking to 5 healthcare experts about which country had the best healthcare system. And they all dissed my favorite, Singapore, because not transparent enough, not this, not that. Singapore spends 4% of GDP on healthcare. Not a single one of these economists said, can you imagine all the social good you can do if you saved 14% of GDP? Every conversation about healthcare is, how do we make sure everybody has all the healthcare they need? And in doing so, we have starved our population, and particularly our most needy, of the other things they need, many of which are more important. Medicare drives a certain type of care. It may be popular, But here's what it really is. It's excessive, it's treatment biased, it's tons and tons of operations, and it's no general practitioners. There are 7,000 geriatricians left in the country, and eventually there will be zero. So as a result, if you're over 75, there's a 50% chance you're on 5 drugs. There's a 50% chance, if you are, that at least 2 of those drugs are contraindicated. You shouldn't be taking both. This is a totally unregulated, out-of-control system whose biggest beneficiary is the healthcare industry. And the people who should be most aware of that are least aware of it, because they're so busy arguing for more healthcare, more access, and all the rest, that they don't realize the system we've built. Now, my interest in healthcare began with my father's death from a medical accident. So according to Johns Hopkins, medical accidents are now the 3rd leading cause of death in the United States. 250,000 a year. Most of them are in hospitals. Almost all of them are among Medicare beneficiaries. Now, it's never listed as a cause of death. Almost no states say medical error. So you're not aware of it. But it's 250,000 people a year, which means in the 20 years since Bill Clinton proposed healthcare reform, we've probably lost 2.5 million Americans. I'm sorry, 4.5 million Americans to errors committed while Medicare was their payer. And we could say, hey, it's all a matter of money, but I just can't believe that. Now, one of the key things that we need to understand about Medicare is its illusions. And the biggest illusion is that it's cheap. How something that has gone from $1 billion in spending to $675 billion in spending in 2.5 generations is called cheap, I have no idea. But in understanding how a public option will work and the incentives it will give to our healthcare system, it's important to understand what Medicare calls cheap. First of all, the biggest thing is it costs almost nothing to administer. Almost everybody who writes in favor of a public option or Medicare for all says private health insurers spend 15% of benefits on just administration. Medicare spends 2%. That's got to be cheap. Something sound wrong with that? Well, here's a hint. Private insurers do Medicare's administration for it as subcontractors. Have you ever heard of somebody who will pay somebody, a housekeeper, who will take less for cleaning other people's houses than he'll pay for having someone clean their own house? That's what you're inclined to believe, that some health insurers are doing administration for Medicare less than they do it with their own money. What's really going on? Well, private insurers say no to things. They judge appropriateness. They judge safety. They judge quality. Medicare's mandate is to say yes to everything. And of course, the great irony is, so it costs $13.5 billion to administer Medicare's $675 billion. But Medicare says it has roughly $70 billion of fraud every year. Now, here's the great thing about government accounting. That $70 billion of fraud, they don't count as an expense. They count it as benefits paid. So, the $70 billion of fraud, by the way, completely eliminates their administrative advantage in cost, what they say is cheaper. But we got to remember, Medicare is a political program. Its constituency is politicians or policy analysts, not business people. If you've run a business, you understand what's going on. Medicare is a bank without security guards. It's the nonprofit model. Look how much money we pay out and how little it costs us to do it. Underlying that, and by the way, a bank could run without security guards, but unlike Medicare, it couldn't tell its board of directors, the money stolen counts as revenue. The second element of Medicare's supposed cheapness, though, is the most important one, which is Medicare pays hospitals and doctors less than private insurance. Well, if you've been in business, you recognize the make-it-up-in-volume fallacy problem there. Again, who's the constituency? Politicians, policy analysts, academics. Who cares what price you pay a hospital if you let the hospital bundle as many different diagnoses as possible? When we look at how Medicare has grown in cost and where that cost goes, to argue it's cheap is absurd. Using MedPAC's own words, I love this. Rapid volume growth may be a sign that some services in the fee schedule for physicians and other health professionals are mispriced. In other words, we pay them so little they do more of them than they should. And that is the story of Medicare. Now, why is it like this? Well, the reason it's like this is because Medicare was based on a very dishonest statement to us and to providers. To us, Medicare says something that no other country on earth has ever said. We're an entitlement. We will pay for all the health care you need. How did the industry respond to that? By endlessly increasing the definition of need. It's so obvious that you'd never have to work in a business to do that. Medicare is dominated by special interests. There's 17 medical trade associations whose CEOs earn between $1 and $5 million a year. It's not to convince Medicare to be more efficient. The health industry spend $500 million a year on lobbying. Our hospitals operate at 65% capacity, 20% less than the rest of the world. They stay in business because Medicare keeps them afloat. We have so few geriatricians because the specialists run the price-setting mechanism. So really understanding how Medicare works makes you rethink what's a public option. What is a public option? It's an option. That sounds like, what could be bad about an option? Except it's nonsense. The people who originally proposed a public option admitted years ago that what they were really trying to do was get to single payer. We see how difficult it is for insurers to price the type of customers that Professor Starr was talking about. Try to imagine the government saying, you can take this option, here's the price. How do we set that price? No idea. Now, what Medicare supporters and public option supporters say is, oh, we'll set it in competition with insurers. But remember what Medicare does, right? It allows large amounts of fraud. It never says no. No insurer can compete with that. Public option advocates like to say the nice thing about Medicare as a competitor is it doesn't need to make a profit. That's not what makes Medicare a competitor. It's that it doesn't care about losses. This year, general revenues, your tax money, will subsidize Medicare to the tune of $320 billion. The price of a public option will be whatever Medicare wants it to be. And when politicians want single payer, it'll be so low that a private insurer can't compete. And if it's too high, by the way, we'll just have a high-risk pool that'll be extraordinary expense. What Medicare hasn't proven, and I mean real Medicare, not the pretend, oh, I wish it were better, we could improve it. It's 51 years old. As a man in my 50s, we don't improve. It is what it is. And what it is the core feature driving the undisciplined supply, pricing, and utilization of care that has so undermined the social welfare of the average American citizen. Thanks. Thank you. I didn't forget that Medicare Advantage exists. Describing it as a marketplace is pretty remarkable. Medicare sets the rates it reimburses, describes the policies fairly in depth. And in fact, I think Medicare Advantage is just a wonderful example of how extraordinarily corrupting the incentives of Medicare is. The theory was, let's create an option for seniors within Medicare. So Medicare Advantage pays slightly more than their fee-for-service number. It depends. It's changed from year to year. And quickly what insurers discovered is the key was to define your benefits so that you got the healthier Medicare patients and made more money. Doesn't sound like much of a marketplace to me. The argument stays, right? I just cannot accept that the primary customer of our hospital sector that allows a 65% capacity industry to operate at a 7 or 8% market is great for controlling costs. I get it. The prices look low. But any of us who've actually been in business know that the price is low is not the same as genuine industrial discipline. Look at the big numbers. And in fact, let's look at the big numbers. There's probably no metaphor used more than the boiling frogs metaphor. And Professor Starr's right. Seniors love Medicare because the alternative is too frightening. But let's pretend somehow that a 65-year-old when Medicare was passed was alive today. Here's what that senior would have found. That the share of health care they pay out of pocket had gone from 10% of their income to 18% of their income. That in an average year, they spend $3,500 of their own money on health care. That Medicare premiums and cost sharing take 25% of their Social Security benefit. Now, just like every other healthcare program we've had, when Medicare was passed, it was going to solve all these problems. It was going to take care of cost control, give you access, and all the rest. The problem of health costs for seniors now is meaningfully greater than it was in 1965. They don't know it because they weren't alive in 1960, or they weren't seniors in 1965. And this is how the entire healthcare system is developed. This is how we got to 18% of GDP. All incremental, helpful ideas like the public option. All things that are really going to make it cheaper and really make it universal. I believe in universal access to care. But the difficulty with the things like Medicare is because they're political programs that disguise their true working, they wind up shifting ever more of our dollars from everything else to healthcare. And we are poorer for it. Healthcare is the 10th most important factor in health, measured by almost anything. You name it. Income, education, safety of your community, marital status, having a job. All of these things have a lot more to do with your health. And as the United States has uniquely gone to 18% of GDP on healthcare, we have less for that. David Brooks referred to the US government as an emerging healthcare state. We can afford nothing else. If you believe that this latest great idea to solve the problem, the 7th or 8th, will have any different result than the others, then I appreciate your optimism. I wish I shared it, because I believe in universal coverage. Over time, like in anything else that matters, the only way we will make sure everybody has affordable health care is to do something meaningful about prices. There's no financial engineering that turns expensive health care into affordable health care. It just moves the money around. And the only way we're going to have health care that has the impact on our lives close to the amount of money we're spending is for it to be good. And while we focus in the political arena all the time on people who don't have access and all the rest, the amazing thing is the fatality rate because of excess, undisciplined care in the United States far exceeds the fatality rate for people who don't get care. It's not part of the discussion. It's not as much fun. It's much more fun to talk about access and be, this wonderful giving person guaranteeing care to everybody. But what has it wrought? What do we really have? And as we think about healthcare down the road, what is it that we want our healthcare system to look like?
Thank you, David. Yeah. All right. In this part of the debate, each side gets to ask each other 2 questions. Paul, would you be willing to go first and ask David a question?
So, David, I was stunned at the end when you said you were in favor of universal coverage. I'm not quite sure how you plan to get there. That might be the first question, but let me also ask you this. You seem to be suggesting that because of the stark character of your criticism, that seniors should just go cold turkey on Medicare.
I understand.
Well, you say Medicare is killing people, basically. You say the healthcare system is killing people, that people who don't get treated are better off than people who get treated.
I didn't say that.
Well, actually, I think if we could roll back the tape.
I said there were fewer.
There were fewer
Okay.
people who, okay. Well, it sounded to me very similar to a doctrine in the 19th century known as therapeutic nihilism. And actually, if you go back to the 1830s, 1840s, therapeutic nihilism was justified because the medicine in that day probably did kill more people. But you've got a kind of updated therapeutic nihilism. You've got a view that the healthcare system is so terrible, putting money into it is so destructive that Americans would be better off if they just didn't have it. We should go back to 4% of GDP instead of what we're spending now. That would mean closing down a lot of hospitals and letting go a lot of doctors and nurses. Is that what you mean?
Okay, that's the question. David, please respond to the question.
Yeah, so, no, I'm not calling for abolishing health care.
Oh, thank goodness.
What I'm calling for, although we should abolish the term, but that's a different subject, because there's talking about 10 or 15,000 different services consumed in different ways in different parts of our life as if it's one thing has probably cost this country more value than almost any other political error we make. But let me deal with what I think you misunderstood about what I was saying. So my focus is on the incentives to practice healthcare in the system we've built. As a history major, I respect the history, but the reality is there isn't a healthcare industry until well into the 20th century in the sense of providing any value and worth arguing over. The issue is the incentives and how we buy healthcare, how does an industry respond? And my argument is the unique American politics and the unique American political structure has so warped the incentives in our public programs that the damage caused by excess care, undisciplined care, lack of the normal responsiveness to consumer need. Look, 75% of care dollars in this country are spent on chronic conditions. And yet we have an industry that packages almost everything on a fee-for-service basis, and all the experiments that Medicare has done to do something different have wound up creating those very monopolies you talked about. I am focused on how care is actually delivered for our 18% of GDP. So I am in favor of universal coverage. I've written a book that if we can understand that what we're trying to insure against is catastrophe, and not warp an entire industry by trying to include everything in this insurance rubric, we will have something that closer serves our social needs and is better balanced in society with everything else. And let me just make one last point. One of the key things I talk about when I'm talking about the island is the fact that there can be no trade-off between what we spend on healthcare and any of our other goals as a society or as individuals. Putting everything into an insurance system, creating Medicare as an entitlement and Medicaid as kind of a part entitlement is absolutely unique in the world. No one else has done that, where there's no leakage. Once it's healthcare, it's gonna get spent on healthcare. It's not, as an employer, it's not surprising to me that the cost of healthcare goes up every year, even though people get healthier, because that's not what drives it. What drives it is these industrial factors. And so when I hear yet another idea for doing more of the same, I can't help but notice that Medicare didn't solve seniors' financing problem in healthcare, neither did Medicaid. The Affordable Care Act has extended coverage, but it's almost useless because of the deductibles. And I also noticed that we've maintained different healthcare systems for seniors, for poor people, for veterans, and all the rest. And I don't think that's just about money.
That's your answer. Okay, David, a question for Paul.
So when I started getting interested in care as an employer, I looked at what a young person is going to contribute into our healthcare system over her lifetime. And so I took literally somebody starting out for us, and I looked at all of the insurance premiums that would be paid in her name over her lifetime, her Medicare premiums, the Medicare taxes, because as you know, we now subsidize Medicare enormously through general tax revenues, the amount she'd spend on Medicaid, everything for the safety net and for healthcare. And I made a couple of important assumptions. One is that, she lived through life, what used to roughly be the average, got married, had kids. I assumed she never got sick, meaningfully sick. And I assumed she never got rich, and she was solidly middle class her whole life. So using a 0% growth rate, the number was $1.2 million. That's what we're asking a 23-year-old today to have put out of her income into our healthcare system to maintain this safety net and to maintain this extraordinarily centralized care. How do you justify that to her?
Well, you've taken that number is kind of meaningless since you're projecting somebody's, but we do spend a lot on healthcare in the United States. It's 18% of the economy. It's 18% of national income and 18% of gross domestic product. Of course those numbers are all going to look big. What surprises me about your approach is that if you wanted to spend a lot less on healthcare, you'd look at the countries that spend a lot less on healthcare. The other rich countries, I mean, not the poor ones. The other rich countries, meaning Britain, France, Sweden, most of the European countries, and they have a lot more governmental control of healthcare than we do. they regulate, they control prices, they control employment in the healthcare sector. So someone who started out with your view that we're just spending so much more of our economy than we should be on healthcare, it seems to me on the basis of the comparative evidence would be drawn to exactly the opposite conclusion, that we need a lot more government control, not less, because really I mean, you may have your Singapore case, but otherwise you don't have you don't have a lot of evidence to support your view, which again, it's really kind of hard for me to decipher what your view ultimately is, that if government pulled out, that the market would operate in such a way that we would be back at a much lower level of expenditure.
Well, no one. Can we just?
Okay.
Can we treat that as our questions to each other? That
Go ahead. Okay, that's your question.
Because I mean, so Singapore may be the most government-controlled healthcare system on earth, but it uses free market principles to exercise that control. This is not, for me, an ideology of whether it's government or not government. That's irrelevant. And the examples of other countries are irrelevant because none of them have our political system. So nobody has a Medicare program, the equivalent of a Medicare program that is run for insiders. The degree by which special interests set prices, determine service, prevent regulation in Medicare is absolutely unique on earth. And I remember once in a debate like this, someone saying, we should have Sweden's system. We don't have Sweden's system of government. What we have is a system of government in which you're always allowed to lobby everything. And to look at Medicare, and it's why I brought it up, and not understand the extent to which, I mean, I would say this to you, you're someone who's been so conscious of special interests over your career. Who do you think runs Medicare? This fantasy that Medicare makes no decisions on appropriateness. When Medicare decided that men over 75 shouldn't have PSA tests, didn't stop paying for them. Half of them still do. When Medicare decided people shouldn't have spinal fusions, didn't stop paying for it. Industry wouldn't let it. Let's talk about America, because America's problem is unique.
Okay, you blew your second question. Paul, you have a second question. You can ask, as I adjudicated.
Okay.
Lob a question at the man.
Okay.
Yeah.
If America's political system is so utterly rotten with special interests, how do you propose, working with the institutions that we have, how do you propose to change it? I mean, it really sounds hopeless.
That's really
it does sound a little bit like Bernie Sanders.
Pessimistic. No, I hate to see that. No, I'm probably the only real optimist in the room, because almost all of our ideas about healthcare are 70, 80 years old. The NHS is 70 years old. This is an absolute dinosaur. Healthcare is changing radically. When the national health system started and we decided insurance should run everything in healthcare, it was a different thing. Healthcare was rare and major and urgent, and the integration into our lives from birth to death didn't exist. So when the big national healthcare systems were created, almost all care was therapy. It wasn't chronic condition, which is the bulk of what we do now. It's already changed in 2 generations with a system that hasn't changed with it. Going forward, we look at a world of personalized cures, something the system hasn't done since we had infectious diseases. What we need to understand is healthcare is a dynamic industry. And the idea that these 70-year-old systems are what should guide us strikes me as absurd. Healthcare is an essential like food. And we used to insist that food be divvied out by the high priests. It was just too important to be left to the markets. The further you are from that, the more food your people have. We need to reintegrate healthcare, which means we want a safety net for urgent things in healthcare. Let's have one. Let's have an insurance system for catastrophes. But if each one of my employees is going to put $1 million into healthcare over her lifetime without her getting rich, her single biggest expense, if that's what we have today, before this newest plan, today imposed on our young people, then we need to stop. And we need to think about, here's what we want a safety net for. Here's where we want to bring in some market forces, competition. Here's where we want consumers to be empowered. You don't need a single idea to solve an industry with tens of thousands of goods and services. It's okay to have a hybrid. And instead what we've done is we look for a magic bullet. And in anything complex, a magic bullet is a foolish exercise. And we are not the only country suffering under very rapidly increasing healthcare costs. All of those other systems are.
Thank you, David. Okay, questions from the audience now.
Because I understand healthcare, there are benefits to having healthcare, but there are benefits to other things. Like, my girlfriend loves Chanel bags, and the fact that, you know, she's getting taxed for like Medicare means that she has less money to spend on Chanel bags. Why don't we like get a public option for like, you know, expensive handbags, right? I mean, and if you ask her, she might even say like, you know, she cares about the Chanel bag right now because she's pretty healthy. So.
Let David. David, you want to respond to that?
Well, I mean, you actually can get Chanel bags under some Medicare Advantage programs, but I think, you know, look, the reality is we have a political system to determine social priorities. A lot of us do believe that there are things about healthcare that is unique, including as a service, that it's not going to work fully with a market like others. I believe that. I don't think that's true of all of healthcare, but I think it's true of a lot of healthcare. We don't want, and we are a wealthy enough country, that everybody in this country should be able to afford high-quality health care, and there are ways society can help do that. The bigger part of your question, though, is really crucial, which is the fundamental reason we and many other countries on Earth have decided that health care is the single most important thing the government should spend money on is probably an old one, and probably a political one. And let's face it, if you're a politician, it is a lot easier to be arguing about access to health care and look at what I am giving you than to address the 9 more important things that contribute to your health. Social structure, marital structure, community safety, education, lifestyles. Those are difficult. Now, it's harder for us to address those without the money. So when I see Singapore paying 4% and think they've got 96% to spend on anything else, I like that. So when I said that a remarkable amount of our healthcare system was based on incredibly old ideas, I was referring directly to what Professor Starr just said. So he's absolutely right. 10% of our population uses 65% of healthcare costs in any given year. So if you plan on living 1 year, that really matters. But by the way, that is less concentration than in any other expensive good and service. In any given year, less than 10% of the population buys 100% of the cars, 100% of the refrigerators, has 100% of the marriages, divorces, you name it. This idea people have been saying in healthcare for 70 years without thinking of what in any given year means. In any given year, 10% of the population uses all of the college education. So what? We live 80 years. This is a question of finance. That has been the argument for having this massively complex, insanely expensive, ridiculously distortive system of insurance pay for everything. That argument. And it has no reference to anything else in human life. It's the island of healthcare. You go to a healthcare conference, you say what Professor Starr just said, everybody nods. But nobody says, what isn't that true of?
Well,
it's true
the,
about, well,
it's the unpredictability.
But let me finish the point. We know that you're going to use a lot of healthcare certain times of your life. Towards the end, at the beginning. We know that your healthcare demand is going to vary enormously over the years in between. We have tons of things like that. Healthcare is unique in that being the argument for creating this thing that adds $400 or $500 billion of administrative costs a year to you. That argument. And it makes no sense if you've ever been in any industry other than healthcare.
Did you want to respond, Paul, to that?
Yeah, because that's not really the point that I was making. The point is that when you have that concentration of expenditures, the normal mechanisms that people have counted on and that they're counting on even with high deductible plans, with your catastrophic coverage, that they don't work. They don't work in controlling the costs.
That's a complete misunderstanding. And I must admit, I hear this all the time from traditional healthcare experts. You know, every argument you have in healthcare is if it doesn't work for everybody all the time, it can't work. Right? No, nothing else in our economy works like that, right? Some things work for some people, sometimes other people. We like diversity of services, diversity in the way you charge, alternatives for how something is delivered. Healthcare, every argument is, oh my God, a consumer-driven system can't work because if somebody's hit by a bus, they're too unconscious to shop for a hospital. I get it. But that is not the argument being made. The argument being made is we are now spending $1 million per person per life on healthcare. We can take a reasonable amount of that $1 million, since most of it will be spent on chronic conditions, and we can finance it in any number of ways that makes that person a consumer,
So
like we do with everything else.
Thank you, Paul. 5 minutes for you, David, to do your summation.
Well, let me start with what Paul said, because he and I are in complete agreement of the dangers of monopoly power among healthcare providers. What he doesn't recognize is that that monopoly power has been encouraged by the major buyer of healthcare, the US government. There's a narrative in healthcare that we're used to, which is, after the war, developed countries recognized healthcare as an essential right to all citizens. And except in the United States, began addressing that need through a variety of different forms. There's actually quite a mix of healthcare systems in the developed world, but what they have in common is they have an enormous amount of government intervention in the markets. In America, this narrative goes like this. Only the United States, because of special interest and because of our unique politics, hasn't made this commitment. But it's coming. It's progress. It's the future. What if that narrative is backwards? What if the fact that these ideas were created when healthcare was fundamentally a one-size-fits-all industry no longer makes sense? What if the reason that every developed country on earth has difficulty paying for ever-growing healthcare, and despite what's often monopoly buying power, can't control prices, reflects the obvious mismatch between how healthcare is paid for and how we need it? What if this idea that everything in healthcare is like a building burning down, an insurance claim, is absurd on its face and sentences us to a system that very well serves bureaucrats, CMS, large insurance companies, and very poorly serves the customer? There's 315 million stories of why our healthcare system doesn't work. Some of them are about cost and access. A lot of them is about absolutely primitive use of electronic health records, despite the fact that Medicare gave $45 billion to create electronic health records. Some of it's about the absolute confusion of going from specialist to specialist or hospital to another service. Some of it is about poor care, accident, error, injury, death. Medicare itself says 1 out of every 7 Medicare beneficiaries who goes into a hospital has an adverse health effect because of an error. What if we have an undisciplined, wasteful, expensive, complex, untransparent healthcare system, not because we don't have access, but because, in fact, the forces intended to discipline it don't? What if the narrative is completely backwards? What if the future of healthcare is much more like other things, actually using information technology to make it work better for the individuals? As we've moved from you have breast cancer to you have cancer, is this healthcare system going to be able to adapt? Is this healthcare system going to work in an era of cures? While we've been going on this historic narrative to be like Europe, to have real coverage, we've missed the numbers. We've missed the fact that the average American young person now will be saddled with over $1 million of healthcare costs, in great part because we built this massive system to protect her from healthcare costs. We've missed the fact that the average senior now pays more out of pocket now than the average senior did in 1965. We've missed the fact that the $1.5 trillion the United States governments, including the states, are going to spend on healthcare this year could instead be a $20,000 grant to half of American households every year. With a $60,000 median income and all of the issues we have, the island of healthcare prevents us from even thinking about that, even thinking about the transformation we could have. Look, there are many people on one side of this debate who are in love with the National Health Service. Apparently they haven't followed very clearly what it's been dealing with in the last couple of years. A 70-year-old model. You know a lot of other great ways of running technologically complex, ever-changing dynamic industries that are 70 years old? I don't. Everything else got disrupted in the last 25 years. The first rule of getting out of a hole is to stop digging. Tonight's proposition is another shovelful. Thank you very much.
Okay, now, please look back at your cell phones. The U.S. government should offer a Medicare-like plan that would be available to all Americans buying health insurance. Kate DeCherbo, would you come up to the stage again? Because we're going to have the final voting. The yes vote was 21% in favor before the voting began. The yes vote went down to 14% after the voting. So the yes vote lost 7 points. The no vote was at 47%, and it went up to 77%. So David Goldhill wins the Tootsie Roll. The noes have it. Thank you to Paul Starr. Thank you to David Goldhill. Please stick around for the party.